Hi, good afternoon, everyone. I didn't hear that. Good afternoon. Yes, that's it. Okay, so we'll start off with some very offbeat topic. Okay, it's the endocrine emergencies, and not very often do you get to see it, apart from DKA and HHS. All right, rarely thyroid storm and circuit and other stuff. Okay, all right. So basic exam question. What is DKA? Just simple three words. Just simple three words. All right. Somebody has to have diabetes. He's got to have ketosis, right? So if there is diabetes, there will be increased sugar, right? There is ketosis. That means there will be some instability, whether it is hemodynamic or CNS, right? And acidosis, of course, alteration of pH. In the exam, even if you say that, all right, you get passing marks. However, in theory, you have to have numbers. Plasma glucose, arterial pH, bicarb, anion gap. Anion gap is the most important. All right, and either serum or urinary ketones. Okay, now what happens here? Well, bit of epidemiology. Diagnosis of type 1 has to be there. Young adults usually. In HSS, it's somewhere, the mortality is somewhere around 15%. It's more than the DKA. Precipitating factors are simple. Whatever conditions you get in ICU, these are the precipitating factors for DKA. Infection, CVA, even trauma, pancreatitis, drug and alcohol abuse. Thanks. Drug and alcohol abuse, non-compliance with insulin. Most of the times, these people, the youngsters especially, they'll end up in the weekend. They'll binge drink, probably have some sort of drugs as well, and miss out on all their antidiabetic medication. That's where they'll end up into all of this. Well, extremes of age, coma, hypotension are the risk factors for mortality. Now, just look at the pathophysiology. Well, nobody really wants to go into all the details. You've just got to mention just three words here. There is formation of glucose and breakdown of glycogen. Easy, right? So that's called as gluconeogenesis and glycogenolysis. There is an impaired intake of glucose by the cells. So something wrong with the insulin. Yeah? Then there is impaired tissue perfusion. So all that blood that was carrying this glucose, which was meant to go into the peripheral tissues, is still staying in the circulation, and then it's causing all of the metabolic problems. Right? There's decreased clearance of ketones, yes, and sometimes they do ask you, all right, what sort of ketones do you know of? That's it, yes, right from the first year MBBS, you remember this, beta hydroxybutyrate, acetoacetate, and acetone, right? Okay. Clinical features, everybody knows that. Polyuria, polydipsia. Now that's quite often followed by mental obtundation. It's caused by two things. One, the ketosis part. Second, hypoperfusion, right? Dehydration. Then we all know about Kussmaul's breathing, the acidotic breathing, and that happens because there is acetone, all right? Acetone spill over. No rocket science here. Airway breathing circulation, mental status, volume status, and then you find out what is the source of infection or any other. Well, this you should know by heart, both in theory and practical. You have to have an arterial blood gas. Okay, right? Do you really want an arterial blood gas? Can a venous blood gas do? Yes, simple, isn't it? So, what is the worrying thing? What is the worrying thing in venous blood gas? If, what is the difference between arterial and venous as far as CO2 goes? Which one is higher? Which one is lower? Right. So venous has to be high. So if there is low CO2 in the venous blood gas, what does it mean? Low CO2 in the venous. That means arterial is further low. Yeah? Got it? Now, what does that mean? Patient is hyperventilating too much. Alright. And in absence of a respiratory alkalosis, if you're getting a low pH, that means that the level of ketosis is much more higher. Got it? कोई doubt तो नहीं है? Yeah. Okay. Now, blood urea, creatinine, take a urine sample, send it for urine analysis, urinary dipstick test, and ketones and plasma osmolality also. Well, now, mild, moderate, and severe, just the same as any other disease. This we've already discussed. Okay. Now, whether it is mild or moderate or severe, I don't really care. Treatment is just about the same. It means that you've got to fix your patient within first 24 hours, beyond which, if you're not able to fix in 24 hours, there is something wrong with your treatment or you. Alright. Differentials. Uremia, lactic acidosis, methanol, ethanol, ethylene glycol, starvation ketosis. Yes, starvation ketosis. There can be an overlap also. Especially, I said, the youngsters on the weekend. Okay, no intake, lots of alcohol, lots of diuresis, and salicylate overdose. Well, not really. So that's control the hyperglycemia quickly. That is within 6 hours, ketosis within 12 hours, and the entire DKA should be controlled within 24 hours. Probably, okay, the spillover can go on to the next day, but that's fine. Fluid therapy. What is the fluid of choice? Anybody? Normal saline, half normal saline, dextrose, balanced. Yeah. All right. So traditionally, what were we giving? What were we giving traditionally? NS. Yes. All right. And what's the disadvantage of NS? Yes. So you got normal anion gap met acidosis by extra infusion of normal saline and large volumes. And on top of that, you have high anion gap with ketosis related acidosis. So what's happening? It's double the acidosis. All right. Okay. Now let's forget about normal saline in our practice from now on. This is one of the landmark papers. All right, this is from Australia. One of my supervisors, Dr. Venkatesh, was there while they were doing this multi-center study, a very brave study where they simply said, okay, we're breaking this traditional rule of normal saline. We will only use balanced salt solutions, right, irrespective of what the practice is all over the country. Okay, and that's what this was published in the intensive care journal, and um, the results were really amazing. That one, resolution of shock. Second, return to the normal biochemical parameters as well as their hemodynamic status. Right. So this was an advantage of giving plasma line. Okay. All right, fluid therapy. After all, you've got to monitor the hemodynamics, the urine output, everybody does that, electrolytes, and the cardiorenal status. Okay. Now, do you guys follow urine chase? What is urine chase? क्या होता है? That means you're chasing something. So urine chase is you're chasing whatever urine comes out, you add 50 or 100 mils to that volume, infuse that in the next hour. Okay? That's urine chase, and that's very important in where you have polyuric syndromes. One is DKA, and give me another condition. DI. Yes, DI. Good. And whatever fluid you're using, do not be afraid to infuse that much of volume in the next hour. So patient supplies 200 mils, you add 50 mils to the volume. So in the next hour you give 300 mils in that particular hour. Okay, patient is passing 500, you give 500. Okay, how much what's the maximum volume of fluid, the maximum volume of urine that you guys seen in a patient with DI? एक आवर में कितना मैक्सिमम आप लोगों ने देखा है? Up to 2 liters. All right. The aim of telling you all of this is don't get scared when you're doing a urine chase. Whatever is coming out, pick that volume, right? Add 50 mils to it and give the appropriate fluid in that particular volume. All right. Sometimes you'll find quite elderly seniors will say, "ये क्या बेवकूफ़ी कर रहे हो कि 2 liters कोई देता होगा?" No, it has to be done that way. If you're doing a urinary chase, if you don't do that, believe me, your patient will collapse. All right. Okay. Next one. What is the infusion rate? Oh yes, potassium rate. So let's. I'll just give you very. So remember, one, potassium correction, second is phosphate, and the other one is bicarb, and reduction of blood glucose. Oh, well, I don't even look at that. Resolution of decay, just go by the urinary ketones as well as sensorium. Sensorium is more important. Ketones can really keep on, body can keep on eliminating these ketones for a long time. Complications, well, hypoglycemia, hypokalemia, and cerebral edema. Cerebral edema, yes, always keep looking at the sensorium, GCS. Would you also have a look at the pupils? Yes. What is more sensitive, pupils or reflexes? Both, right? Okay, cerebral edema. That can. Why reflexes? Sometimes you can get electrolyte changes. Potassium causes muscle paralysis. Even if the potassium is okay, you're still getting muscle weakness. What is wrong? Phosphate. Okay. HHS, just about the same thing. Glucose concentration is quite high, about more than 600. Um, Severity is quite intense. All right. Consciousness, obtundation, and even seizures. Well, I haven't really seen seizures, but it's mentioned. Okay. Now, yes, sometimes you can be asked about how would you differentiate between DKA and HHS. All right, so that's a table. It's available all across the net and it's available in every textbook. So before going to the exam, always have a look on what is the difference between these two, right? Okay. Again, clinical features are just about the same. Okay. Yes. uh, Leukocytosis and precipitation of thrombosis also is also very important. Biochemical parameters, you will get potassium phosphate and magnesium, right? So you must always, second day, always look at all these three things: calcium, magnesium, phosphate, right? Some people do LDH as well. That's a marker of cell death, right? Again, the same thing. Okay, so lots of water deficit, and now how would you resolution this again? All right. Okay, so now I'll tell you the just some basic basic workups and how I proceed to do it, and that's how you can. All right. Um, every physician has his own practice. So you get somebody from the ward who has come down with very high sugars, um, and who's already taking insulin somehow, right? He's gone into ketosis, altered sensory, right? That's one set of patients. He's already in hospital. There's another one coming from the community. Okay, uh, same diabetes, same age. The one who comes from the community has much more severe symptoms and the presentation is much more acute as compared to somebody who's in the ward. They've already received treatment. There's something not that was missed. That's why these patients have come in here. Straight away jump in. You make a quick diagnosis of yes, urinary dipstick, pull out the bloods, put an IV line, start off with fluids first. Okay, inotropes can come later on. They indicated, I won't say. Yes, the moment you're putting a cannula, right, that time you draw all your samples, including a venous blood gas. Arterial baad mein hota rahega. Okay, once you're getting a saturation that's good, that's about 95. I don't care about ABG, I just pull out some PBG sample. Okay, once you've done that, all right, so start off 2 IVs. Okay, keeping in mind what the blood pressure is like, what the sensorium is like, and what is the urine output. Okay, now if you have lots of derangement of the metabolic parameters, you can always go in for a central line, okay, or a peripheral and a long line. Okay, so in this peripheral line, you can have a 3 lumen clay connector. Okay, you can give fluids as well as insulin from there, and from the other long catheter, reserve that one for potassium. Yes. Okay, because sometimes you'll get a potassium 3.3 and you cannot then you cannot give insulin. You cannot give insulin if the potassium is very low, because it will further compound hypokalemia. All right. Now, if it's a three-way thing, 2 from here, 1 from here, or else straight away go femoral. Femoral is the vein of choice. when it comes to handling emergencies, hypotensive emergencies, right? Don't go in for jugular. They're already, if you can, that's fine, right? Femorals, very easy, okay? Cannulate them, 3 lumens, fluid, glucose, potassium. That's it. All right? Is it clear? Now, this this one is tricky. All right. Critical illness related corticosteroid insufficiency. Whether this phenomena is common or not, I really doubt, because until now, in acute illness, I really haven't seen this. Yes, um, in the non-emergency scenarios, I've seen 2. Okay, that actually responded to corticotropin test. Okay, so what are they going to ask you? What is it? Okay, so steroid related insufficient steroid related problem. What do they do? Well, the hypothalamus, in terms of stress and infection, it releases CRH. CRH goes onto the pituitary and it releases corticotropin to adrenals and then steroids. Right now, that goes into peripheral tissues. Okay. Now, what happens? Why do we give steroids? Why do we give steroids? Just the 2 reasons. Just 2 main reasons. Um, uh, in the ICU settings, and they are: one, yes, okay, ARDS or whatever. All right. Why do we give it? My question is, why do we give it? What is the pathophysiology behind it? How do steroids help? Right, right. Coming down to the cellular level, what happens is steroids increase the sensitivity of vasopressors and inotropes on the myocardium. That's the one thing, right? So the lower the pH, then your inotropes don't really work as efficiently as they do on a higher pH above 7.2, right? So one, getting the pH up. Second, putting in steroid. These are 2 things that make that give you some bit of a control over your managing hypotension. All right. So that's the 2 things. Second one was in a study they found. Which study was that? Steroids. They found that they reduced the duration of shock. Corticus. Corticus. Yes. All right. Now, what are the signs? Fever, asthenia, whatever. Okay. In our settings, in the ICU setting, there's only one parameter that you look at. Okay. There's a non-resolving shock that's going on. All right. And nobody actually does hemorrhage necrosis of hypothalamus or pituitary or adrenals, right? On KUB, always when you're ordering a KUB ultrasound on any of these patients, for looking at any intra-abdominal cause, apart from the kidneys, always ask the serologist what is the renal parenchymal structure and how do the adrenals look like. That's it. That'll give you all the answers. All right. AKI for renal parenchyma and CERCI for adrenals. Yep. Okay. So total random cortisol of less than 10 milligrams or after ACTH of 250 microgram test. Now, it's only very few times that I've done this, but not to my excitement. Right. Resuscitation with steroids, reevaluation. And okay, so you want to do a synactin test. So they do ask what is an ACT each test and the synactin test that you do for renal insufficiency. And um, what is the interpretation of that? So would you that takes about 6 hours or so, right? 3 hours to 6 hours. Would you wait for steroids not to be given just to see what the test is like, or is there any way out? Use hydrocort or methylpred. Normally hydrocort, isn't it? We use hydrocortisone. So if there is a shock going on, you want to do a synactin test or an acetate stimulation test. You do not wait for hydrocort to be given. You do not wait for 6 hours. You simply give dexamethasone first and then switch it over to hydrocortisone, right? And why is that? क्यों करते हैं ऐसा? Yeah, go ahead. Because dexamethasone does not interfere with the assay of cortisol. Okay, hydrocortisone does. Chalo. It's just that dex has to be given only once, and then you can switch it over to hydrocort. All right. So, what are the recommendations? Well, you can consider it. Then obtain a serum cortisol in critically ill, right? Hallmark is eosinophilia. If you tell the examiner hypotension with eosinophilia, yes, I'm suspecting Serki, he'll be happy. All right. Okay. Then, if you already have a cortisol sample of less than 10, right, then perhaps you can go with a stimulation test of 250 micrograms of ACTH. And yes, so once you've given steroids, अब सवाल आता है, well, most of the time, yeah, trainees ask. So we've given steroids, we started that 2 times a day, 3 times a day. Now we've got to taper it. Well, you don't really have to taper it if it is less than 7 days. More than 7 days, 8 days, 10 days, yes. Then say you taper it down to 25% per day, or if you see that yes, they really don't require it any longer. Okay. Now, quick thing about thyroid disorders, right? There are two things: thyrotoxicosis as well as myxedemic coma. Now, you can get some exam questions out of it. Thyroid storm is asked both in intensive care as well as anesthesia exams. Okay. Now, you just remember that okay, conditions are just about the same, just like DKA HHS, apart from the fact that you've got deranged thyroid functions. All right. Well, agitation, lethargy, fever, right? Any patient who gives a recent history of loss of weight, rapid loss of weight, high temperatures, okay, in absence of any infection, arrhythmias, yes, arrhythmias. Loss of weight is the most important one, because you might be thinking about this infection, tuberculosis, malignancy, whatever. Until and unless you get a thyroid profile, you'll not be able to pick it up. Okay. Yes. Resting heart rate. Their sleeping is still have a heart rate of say 140. All right. So that's where you can suspect this. All right. Stomach upset, diarrhea. Yeah. Okay. Now, Diagnosis is clinical. You see the temperature, cardiovascular dysfunction, central nervous system, heart failure. What is the precipitating history? GI, hepatic dysfunction. Okay. So the question that is asked is about how do you treat thyroid storm? Okay. Now, DDs, malignant hyperthermia. For those who are going for the anesthesia exam, you must mention NMS, neuroleptic malignant syndrome. Okay? Acute mania and gut. Well, SSRIs, yes, SSRI medication also can mimic all of this. So if you have poisoning case coming with a youngster coming with SSRI thing, you should also look at the thyroid function. All right. What is the treatment? Propanol, iodinate, potassium iodide. Always give steroid here. Always give. It has a membrane stabilizing effect. All right. So, propyl thiouracil and methimazole. It's, what's the trade name for this? Methimazole, propyl thiouracil. Yes. Neomacazole. Yes. Okay. Well, um, other supportive care, yes. Fluids, cooling blanket is a must. Oxygen therapy, ventilation. First of all, go ahead and give some beta blockers. Beta blockers first, control the temperature. If you can't control the heart rate or the temperature, no matter how much pneumocazole you give, nothing's going to happen. Okay. Now, sometimes you do get thyrotoxicosis factitia, which is anti-thyroid medications, right, or iodides are not useful in it because people have intentionally taken thyroxine. Just opposite to that is this myxedeme coma, which has a high mortality of 30 to 50%, and it's often misdiagnosed because we do not consider this as a possibility. Okay. Trauma, infection, burns, these are the precipitating events. Most often, all of this, the risk factors as well as precipitating factors in almost all the diseases are just about the same and can precipitate all of that. Failure to start thyroid therapy or omission of these medications can lead to this. And when do these people land up into myxedemic coma? Elderly ladies, right? What is the hallmark there? Elderly lady on antithyroid medication, failure to lose weight, stomach upset, or intestinal obstruction, where they may take the medication, but over several days it's not absorbed. They just vomit it out, and slowly myxedemic coma sets in. That's where you must ask the history of taking thyroid medication and recent abdominal problems, digestion problems, diarrhea, vomiting, and stuff. Okay. Here are two things. One is mental obtundation. You touch the patient, it's cold, and at the same time, look at the GI tract also. Coarse, dry skin. Touch the forehead, it will be coarse and dry. Hands, neck. Okay. On physical examination, you can find out that these are things happening. Where else do you get coarse, dry skin? In which other condition? Kidney diseases. Yeah. CKD patients. Haven't you seen the legs? Myxedemic differential is hypoglycemia, malnutrition, exposure to alcohol. No, forget it. All right. Yes. Last slide. No, not the last, but okay. So, how do you treat it? Do you think T3, T4, IV is available here in India? Has anybody used it? No, it's quite difficult. It's quite difficult. Okay, but in patients who have an intact gut, then what they do is you crush two large thyroid tablets and give it and hope for the best. But in an exam, you need to tell that IV T3 and IV T4 can be given. T4 400 and T3 you can say 5 to 20. Okay, so these are the two. Apart from that, you have to give glucocorticoid. So with thyroid, adrenal, right, hypothyroidism, right, or adrenal problem, all three of these require steroids. Blanket rule. Well, there might be a coexisting adrenal insufficiency in thyroid disease, right? What else? What else can you have when it's thyroid problem, right? Weakness related with which? With which electrolyte? So take it like this: thyroid and parathyroid both are together, right? So you've got a thyroxine problem, right? And then you've got some weakness also. Always check calcium, right? And and uh, can you check it from venous blood gas? Ionized calcium, simple. ABG is, or VBG is, the blood gas analysis is one of the best investigations and the most useful investigation that has a direct impact, on patient management on the spot. Alright, there is no other investigation like a blood gas that has such great impact. Okay, you see the number of things that you get in the one go. Alright, okay, provided you're designed to think that way. Okay, so hydrocort is usually given intravenously, alright, and then for first 6 to 8 hours, and then for several days. Treatment is supportive, ventilation, hypoglycemia, yes, sodium correction in hypothyroidism or myxedemic coma. Always look at the sodium part. Okay, so all right, so in the end, endocrine emergencies are uncommon, but they are life-threatening, high mortality, quick history and focused exam, whether the patient is coming from the ward or from the community, then a rapid initiation of specific therapy and most important, supportive care, and keep your ideas open. Alright, always don't limit yourself to only infection, malignancy, hypotension. You expand your think out of the box. All right, can we look at all of this as well? All right. Okay. Thank you. Any questions? All right. Thanks.
Thank you, sir.